During this ESMO, we reported data about the 4 years total progression-free survival and overall survival for the SECOMBIT study. The SECOMBIT study was a randomized Phase II study which explored the best sequence. We enrolled patients in 3 different arms. The first arm with the combo target as first in case of progression, combo immuno with Ipi-Nivo second. Second arm, combo Ipi-Nivo as first, and then in case of progression, combo target with the Encorafenib Binimetinib, and then the sandwich. The sandwich means immunotherapy put in the middle of 2 courses of target therapy. Enco-Bini given for 8 weeks, and then the switch at response to Ipi-Nivo, and then in case of progression, again, Encorafenib Binimetinib. Overall survival is the main endpoint. And we confirm in terms of total progression-free survival and overall survival with a median follow-up of 43 months, that the arms where immunotherapy was given as first went better than arm where target therapy was given as second. And one of the main reasons is that looking the response rate of Ipi-Nivo, when given as first was 46%, is when given after target therapy 25%. So this means that the resistance to target therapy affected the response to immunotherapy. We've also seen data about the subgroup analysis, and it's interesting that in patients with elevated LDH, the sandwich arm went better, and this may be an option for these patients to give just a short induction of TKI, and also for the patients with high tumor burden with more than 3 sites of metastasis, still immunotherapy went better when given as first. About the biomarkers data, we showed the preliminary results, very preliminary, just on 90 patients. We're evaluating the cytokine in the serum, and we're evaluating with the next generation sequencing about 400 genes in a group of patients, 93 patients. And the most interesting data come from the tumor mutational burden, because if you have a high tumor mutational burden in arm A and B, the patients went better. While in arm C, this was not seen, probably because it's more affected by target therapy. About JAK mutation, we have seen that when present, arm B, so immunotherapy is first, went really better. So the 100 of patients are still total progression free, and also in terms of overall survival, all the patients are still alive. The limitation is that we have a small number of patients, and so of course we should look at this with more simple. And finally, looking to interferon gamma cytokine, not signature, the interferon gamma cytokine in the serum, surprisingly, if low in arm C, the patients went better. Again, the limitation is the small number of patients, but these are the data that at the moment are interesting.